Okay, I'm just going to wait a little bit longer. Okay, so I think we'll start. So welcome to the Australian Primary Health Nurses Association webinar on the top tips of understanding the tier system with our guest speaker and subject matter expert, Megan Reilly. Also on our panel today and assisting with the Q&A is our subject matter expert, Margaret Jennings. My name is Lisa Sinkins and I will be your facilitator today. Also on our panel today is Sarah Drew, who is the Nurse Programs Manager for the IPC Helpline. We would like to start by acknowledging the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures, and to the elders past, present and emerging. Okay, so today's webinar focuses on the Victorian tier system and that's part of the Infection Prevention Helpline in association with Murray PHN. Our service is designed for all clinical and non-clinical staff who work in general practice, community pharmacists and Aboriginal controlled health organisations and is supported by our subject matter experts. If you have any questions around infection prevention and control, we encourage you to call us or go to the webpage to submit a web form with your questions or book an appointment with us by using the details that are currently displayed on the screen. The helpline doesn't just focus on COVID. You may want information on updating your current policies and procedures. So please contact us free to ask all your IPC questions. Okay, so our presenter today is Megan Reilly. Megan is a registered nurse who is the Director of Hands-on Infection Control that is based in Western Australia. So the Infection Prevention Helpline has received inquiries around the tier systems and how to identify workplace involvement when a staff member has been exposed and how to explain it to patients. And we'll also discuss about the PPE tier system. So the learning outcomes that you should take away today are you should be able to summarise the 3-tier system that is used to classify COVID-19 exposure sites, explains the difference between a close contact and a casual contact in relation to COVID-19 transmissions, determine what PPE should be used for the treatment of individuals, recognise the importance of keeping up to date with the current exposure sites and the ratings and the health advice, apply procedures and activities in accordance with the current risk rating for your area as per guidance. Okay, so I'll hand over to Megan.
Thank you, Lisa, and greetings from Western Australia. It's actually morning here still, but good afternoon to you all. Now, the Victorian Health Service Guidance and Response has been developed to inform health service processes and interventions in response to changing risks of COVID-19 transmission in the community. The VHSGR, as it's referred to COVID-19, lists 4 risk ratings ranging from low, which is COVID ready in the green, to very high, which is COVID peak in the black. The risk levels will be influenced by several factors, and these include, but are not limited to, COVID-19 prevalence within the state or the geographic area, the prevalence of COVID-19 cases in at-risk communities, and the number of COVID-19 cases of an unknown source over a particular time frame. So each rating on the VSHGR reflects the risk of COVID-19 transmission within the community and how a health service should respond and prepare to reduce that risk. As the risk of COVID-19 transmission increases, so does the level of interventions health services are required to implement, such as increased PPE usage or enhanced patient screening processes. Where there are differences in the levels of risk across the state, health services in areas where the risk is very low will be able to continue to provide a normal service provision. For example, with hospitals, that will be elective surgery, maybe outpatient consultations. But services in high-risk areas will need to adapt their processes to align with the relevant risk rating of the VHSGR. So that, for instance, could be increased personal protective equipment use or restriction on visitors. So where the risk changes, a pre-agreed suite of actions and tasks will need to be implemented by health services, enabling the health system to A, mitigate the risks of COVID-19, to maintain normal service provision, to alleviate pressures on the testing services, to decrease avoidable presentations, and to optimise PPE use across the state. So changes to COVID-19 risk in the community is discussed at the Department of Health COVID operational leads to determine whether the risk level of the state, the region, or an individual health service needs to be changed. If it does need to be changed, then the Department of Health will enact and they'll communicate that decision to the health service CEOs and also load it up onto the VHSGR webpage. Health services will be required then to communicate any change in the risk ratings to their staff so that appropriate changes in practice and service provision can be made. This includes amending PPE provision, implementing relevant patient and healthcare workers testing, and modifying service provision. So on the slide, we can see what the current risk rating is in Victoria and has been since the 23rd of August, which is COVID peak, and it's across the state. That's as of the 22nd. I haven't had a quick chance to have a look this morning, but I have no doubt it's exactly the same. Moving on to the next slide, there are 3 COVID-19 case alerts or exposure sites, and these are based on the risk of acquiring and transmitting the virus. So Tier 1 exposure sites are of greatest risk, Tier 2 exposure sites are of moderate risk, and Tier 3 exposure sites are of low risk. The exposure sites are listed on the Victorian Government Coronavirus website and are updated continually and sometimes as frequently as hourly. And on the website, it lists the suburbs, the exposure site, the exposure period, the tier level applied, and the associated health advice with that. So if we look at Tier 1, these are exposure sites where people attending are at the greatest risk of catching the virus or transmitting the infection to others. And these are considered close contacts. So if a close contact has been to a Tier 1 site, they must immediately isolate, get a COVID-19 test, quarantine for 14 days from the date of exposure, and get tested again if symptoms develop. And it's important that even if they have a negative result, they must remain in quarantine for the 14-day period. Tier 2, so these are exposure sites where people attending are at moderate risk of catching the virus and transmitting the infection to others, and they're considered casual contacts. So if someone has been to a Tier 2 site, they must immediately isolate, get a COVID test, quarantine until that negative test result is returned. If symptoms do develop, then of course they need to repeat that, immediately isolate, get tested. Tier 3, so these are precautionary measures or precautionary exposure sites where people attending are at lower risk of catching the virus and passing the infection on to others. And these tend to be sites where a person has briefly passed through. They still pose a risk, and that's due to the high transmissibility of some strains, as we're experiencing with the Delta strain at the moment. So if people have been to a Tier 3 site, then they must monitor for symptoms, and if symptoms develop, they isolate, get tested for COVID-19, and they quarantine until their negative test result is received. So that gives us an explanation of the tiers. Now, providing a safe work environment is the key principle used in the development of the VHSGR. And as a result, where the risk of COVID-19 transmission increases, so does the environments and the settings where healthcare workers are required to wear P2 or N95 respirators. So the framework will tailor the PPE recommendations to the risk that's present at the time. And in times of very low risk, will ensure that healthcare workers have optimal protection, and that's maintained, while not recommending unwarranted PPE use, which can actually result in unintended consequences for the healthcare worker. So the Victorian response to COVID-19 risk is not about preserving PPE, it's actually about optimising the use of PPE so that healthcare workers with the highest risk area, within the highest risk areas, are actually adequately protected, and to avoid, again, any unintended consequences of wearing PPE, such as unnecessary skin discomfort, skin pressure injury. Increasing the difficulty communicating with patients is another consideration as well. So this slide actually provides a framework for assessing the level of exposure risk to COVID-19. And as we can see on the slide, if we're caring for individuals with confirmed COVID-19, or caring for individuals with individual epidemiological risk factors with or without symptoms that are consistent with COVID or some other acute respiratory illness, or we're caring for individuals with no individual epidemiological risk factors and symptoms are consistent with COVID or acute respiratory illness, and they're in a known local transmission, then this would be of higher risk. And therefore the PPE recommended in this situation is a P2 N95 respirator with protective eyewear, preferably a face shield, and other PPE, which would include a gown and disposable gloves. Now, if we were caring for an individual with no individual epidemiological risk factors and the symptoms and consistent with COVID-19 or acute respiratory illness, but there's no known local transmission, then this would be considered of lower risk. But I think it's probably important to state that we would still need to assess for other risk factors to determine if a higher risk precautions were actually warranted in this situation. So the PPE that would be recommended for this scenario would be a surgical mask, and then as per standard and transmission-based precautions, protective eyewear and other PPE as required. If we're caring for asymptomatic individuals with no epidemiological risk factor for COVID-19, then we would manage that individual as per standard precautions and transmission-based precautions if they had some other infectious disease that wasn't of a respiratory nature in terms of COVID. Next slide, please. Okay, so this table provides advice on appropriate health service procedures and activities at COVID peak, but I'm sure you're all aware that there are health service guidance for each of the stages for COVID. I'm going to focus on just the PPE tiers, but you can see that there are other health service guidance recommendations there as well. So this actually assists us to determine the appropriate levels of PPE use, so tiers 1 to 3. And I think it's probably important here to state that that's not to be confused with the tier 1, 2 and 3 exposure sites. Being a Western Australian, we don't use the PPE tiers in the same level. And personally for myself, I've actually found it a little bit confusing at times. And I can understand why others become confused as well. We'll move on to the next slide because we can drill down a little bit further. Great, thank you, Lisa. So this table actually outlines the required PPE for healthcare workers based on the current public health service advice. So the guidance is regularly reviewed and it's updated as required, including in the event of increased in community prevalence of COVID. So it was last updated on the 29th of July, and that was actually to reflect patient status and the minimum requirements for that for the current point in time. I think probably it's important also to note at this stage that PPE is only one element of healthcare worker protection, and it's essential that the hierarchy of controls are implemented in its entirety to reduce the risk of COVID-19. So if we take a closer look at this table, we can see actually that there are 4 tiers. So tier 0 is really not applicable at this point in time and this stage of the epidemic within Victoria. Tier 1, which is referred to as COVID-19 standard precautions, with one change, is used. We use these PPE when we're caring for and exposure to all COVID-19 negative patients. So you can see hand hygiene, which is imperative at all tier levels. Gloves and gown or apron would be worn as per standard precautions, and a minimum level 1 surgical mask is required. Now, recently with the increase in the community transmission, the table was actually adjusted to include the wearing of eye protection for all exposure to COVID-19 negative patients. And that's in the COVID active stage, but it's also in the current COVID peak stage. Tier 2 is droplet and contact precautions. So this is if we're caring for or exposed to low risk suspected COVID-19 patients, excluding those patients who are undergoing an aerosol generating procedure or are demonstrating aerosol generating behaviours. So again, hand hygiene is imperative, the wearing of disposable gloves, a level 1 gown and a plastic apron, or a level 2, 3 or 4 disposable gown, and a level 2 or 3 surgical mask. It doesn't require the wearing of a P2 N95 respirator, but it does require the wearing of eye protection and preferably a face shield. But again, as no doubt you're probably aware, because of the increased risk of community transmission, and in line with the VHSGR, now because we're in the COVID peak stage and with that community transmission, Tier 3 PPE is recommended for all exposure and care and contact to both low risk but high risk suspected COVID-19 patients, confirmed COVID-19 patients, and those who we're performing aerosol generating procedures on, or those patients who have aerosol generating behaviour. So we come down to Tier 3 and we can see that hand hygiene is essential with disposable gloves, a level 2, 3 or 4 disposable gown, an P2 or N95 respirator, and eye protection, but preferably with a face shield. Now, there is a notation that where a patient's history cannot be obtained, they should be considered as a low risk suspected case until further screening information can actually be obtained, and at which point a revised diagnosis of that person's condition can actually be made, and then appropriate changes to PPE if that's indicated. So I can see why people do get confused, but I do find that this table is quite useful, but certainly it has to be read and reread in line with the changing situation and the guidance that we receive. On to the next slide. Now we've popped this slide in because I've actually found it really helpful when actually trying to determine what is the risk to healthcare workers. So it's from New South Wales Health. There will be some items, particularly in relation to testing, which may not be relevant because of a different testing regime from New South Wales to Victoria. But I think the important thing is to actually focus on the table. So it's a useful resource that can actually assist you when you're doing your healthcare worker COVID-19 exposure risk assessment. And we can see that that actually ranges from up the top, from no contact through to the highest risk scenarios. And then down here on the left-hand side, we can actually see the level of PPE worn when having contact with cases. So if we just start at the top, we can see that even if no PPE was actually worn and there was no contact with someone who was COVID, then the risk is actually very low. But that risk then changes as the scenario and the risk factors change. So if we look at transient contact, so this is not actually coming into face-to-face contact with a positive person, or not being, you spent less than 30 minutes actually in a closed space with that person. There is, and you're not worn PPE, then there is a moderate risk or a high risk, depending on the individual risk assessment. And as we move across and the scenario has more risk factors, so there's very close face-to-face contact within 1.5 metres for less than 15 minutes, or maybe for greater than 30 minutes in a closed space, then the risk remains high and it continues to remain high. However, if we then go down on the left side of the column, and as we move through looking at the PPE that is actually worn in relation to masks and protective eyewear, we can see that the risk always stays low if there's no contact, regardless of whether you're wearing facial protection or respiratory protection and eye protection or not. But it does actually change as, again, we move across those scenarios. I think if we come right down to the bottom where we have a healthcare worker who wears a P2 N95 respirator and they're wearing eye protection and there is no breaches so that they're donned and doffed correctly, and whether the case that you're coming into contact with is wearing a mask or not, regardless of the scenario, from no contact through to high risk, that risk remains low. So I think that's reassuring, but it really points out how important wearing your PPE is, donning and doffing it correctly, and of course with hand hygiene. Can we just click on the next? I've just got a little bit to add to that slide. Thank you. So this just provides you some principles around PPE breach risk assessment. So if it's a low risk breach, moderate risk, or a high risk, and what those breaches may well be in terms of incorrect use and exposure, and what the actions would actually be in that situation. Whether it's low risk, medium risk, or high risk, then you would be removed from that situation. You would remove your PPE, you would perform hand hygiene, and depending on the risk breach, moderate, you would be screened and tested and monitored. If it was high, you will be certainly closely monitored, screened and tested, and considered for removal from clinical areas. So a useful tool, I think, for people. Moving on to the next slide, just a few tips in relation to what we've discussed already. I think it's really important that we all keep up to date with the current risk rating. I'm based here in Western Australia, where we've been very, very fortunate with our situation, although I'm sure it will change. I think we've just had a positive truck driver, but it's been considered very low risk, and business as usual, including the finals for the football this weekend. But I still look at the risk rating each day and more frequently if I need to. It's important too to keep up to date with the public exposure sites and the associated health advice. And as I indicated earlier, these are changing continually. And I've provided the link there for you to be able to go on and have a look at that, and then the associated health advice. And the other tip is then to apply that health advice. So apply the procedures and the activities in accordance with the current risk rating. I know we focused on the peak risk rating at the moment, but that's what's most relevant and what's probably most concerning to people. So in line with that, I've just popped in a couple of slides in relation to, it's not just about, minimising the risk of exposure and transmission around the use of PPE, although we know that that's important in the hierarchy of controls. But there are certainly a number of other strategies that go together to reduce that risk that you can implement in your practice, and I'm sure that you are doing the majority of these already. So pre-booking appointments, either online and or over the telephone, screening questions. So when people actually ring to or book their appointment, that there's a series of screening questions around history, epidemiological factors, and also clinical factors, and that at that point in time you're providing the infection control procedures and the expectations. That we're screening staff, visitors and contractors, because we're wanting to continue business, and so these people will be coming into our practices and our health services, certainly minimising people in the waiting areas, and you can be very innovative and creative, both indoors but also outdoors as well. Restricting attendance time, so keeping appointments to less than 15 minutes unless it's not conducive to that person's current health status. limiting the people present in the consultation, so it's the patient and one other person, usually a significant other. Dedicating and separating your pre and post waiting and vaccine administration rooms. Physical distancing, so we can do that between patient chairs, but also staff and patients unless physical contact is required. And also between staff in the office setting, and particularly in areas where staff sort of commune, so in staff rooms. Mask wearing by both patients and staff, and again, the PPE use will be dependent on the risk level and the tier level, which we've just been through for the peak current rating. If we can just go over to the next page. Displaying your signage, so that's all around the basics of infection control, hand hygiene, respiratory hygiene, and the physical distancing requirements. Ensuring that you've got adequate availability of hands-free alcohol-based hand rub stations, tissues, and lined waste bins to dispose of those tissues. Installing sneeze guards, barriers, and we can do that at reception areas. Increasing the cleaning and the disinfection of high-touch surfaces using a TGA approved agent. And these are all listed on the TGA website, and again, they're changing on a daily basis. And so there's some examples there of the routine cleaning and also enhanced cleaning and disinfection. And again, particularly of shared workspaces for staff. Our environmental management is also critical to our strategy. So that's ensuring that you've got adequate ventilation. What we're really wanting to do where possible is to increase the introduction of the outside air. So if you can open windows and doors to increase that outdoor airflow, that certainly helps. But being aware of what your ventilation status is within your building or the area of your building, and does it meet the indoor space requirements. And of course, other things such as removing anything that is communal, so toys, magazines, the water cooler, etc. Interestingly, I've been in the fortunate position to have had a week off last week and flew to Darwin, return. And when you go on a plane, there's nothing that you can really handle. There's no magazines to read and everything's disposable. So they've put in their risk mitigation strategies as well. And lastly, think about your entries and your exits, and where possible, trying to have those separate or have alternate access and egress points. And that's all from me.
Wonderful. Thank you, Megan. So I'll hand over to Sarah now to look at some questions that we might have.
Excellent. Thanks, Lisa, and thanks, Megan, for that. We have had a number of questions submitted pre-webinar, so we might just start with those. If anyone that is on the webinar has any questions, please feel free to enter them into the Q&A box. You cannot vote in there as well, and so we will get to those. Any questions we don't get to in the session today, we will certainly complete post-webinar and get those out to you with the recording. So we might just start to Megan and Marg with the first one, which is a family member in the same household has been identified as a close contact at a tier 1 site. What do I have to do now?
Who do you want to answer that?
Marg, would you like to answer that one?
Go for it.
Oh, I will. So I'm now going to put myself in the situation of I'm a nurse in a general practice and somebody in my household has been pinged as a close contact in a tier 1 site. Have I got that? I've understood that.
Yeah, excellent.
Right. Well, we also look at contacts of contacts, as you know, in the context of this. So the person who's been pinged, my family member, close contact, they've got a lot to do, as Megan said. They've got to get tested, they've got to quarantine, and quarantine is the correct word, not isolate. Isolate's the person who is actually infected, but we're waiting for the quarantine person to develop an infection. So I'm keeping right away from them, but I am now actually a contact of a close contact. And I think I've got some responsibilities in terms of work. I've shared the house with this person. We know how infectious Delta is, and it would be completely irresponsible for me to turn up to work, because I insist with my clinics that we actually ask each other before we go in the door, any headaches, runny nose, anybody in your household in quarantine, and all of a sudden you go, oh yes, there is, but I'm okay, because guess what? As healthcare workers, we just think the same as everybody else. So no, I won't be going to work, and I will be doing the things that are required of me, as well as caring for that person who may in fact turn positive. I won't be too close, because it's not a given that I have to get it. And of course we are immunised. There's actually been a recent paper just come out yesterday about the exposure of people who are immunised to others in their house who have got COVID. So
Mike, do I need to get tested?
The person who is the close contact gets tested. I would be considered a contact of a contact, but I can actually remove myself, or the person in the house, if they can't remove themselves, if they can't separate from me, they go off to a hotel. So we do everything we can.
Saying is the exposed person needs to isolate themselves. So in their
quarantine themselves.
Me as the close contact of that tier 1 exposure, I need to also get tested. If I return a negative result 3 days after getting tested, can I then return to work, or do I have to stay out away from work for 14 days?
Because I am linked. I've got to stay, because I am now linked to the close contact. I'm actually waiting for my close contact to become positive, and that's going to take 14 days. So you would have seen in Victoria how once the person, the close contact, finally gets through their 14 days and is negative and is released, you see this huge number of people who are released, and they are all their household contacts. Don't go to work.
Alrighty, so the next question that we have, and it's interestingly because we've had a couple coming in the chat for this effectively, so I'll break this down into 2 parts, and I might go to you next, Megan. So if the whole practice wears PPE in a high-risk community, do we need to isolate if there's been an exposure, and do we need to close the practice? And certainly we've just had Andrea, I would say, ask the second part to that question, which is how do we stop becoming a tier 1 in GP land without stopping all the face-to-face visits and vaccine clinics? So I guess the first question is, if the whole practice is wearing full PPE, including an N95, in a high-risk community, do we need to isolate if there's been an exposure? And do we need to close the practice?
Okay, so if a confirmed case of COVID-19 has attended the practice while they're infectious, then we would be firstly notifying the Department of Health if they've not already been in contact with the practice, and provide all of the contact information. And in fact, when you go online, there's a spreadsheet that allows you to document all of those contacts. The department will then determine the exposure site tier level, and they'll assist the practice to risk assess that particular situation and determine or identify who are close and casual contacts. But I think it's important that each staff member will actually need to be assessed individually for the risk level, depending on their role and the contact type and the PPE that they wore when that person was within the practice. So if it was a tier 1 exposure site, the staff present during the exposure period may well be required to get tested urgently and quarantined for the 14 days, unless they're identified as a tier 2 casual contact, and then they may only be required to isolate until they return a negative result. But if full PPE has been worn and there's been no breaches, and that's why the individual risk assessment is so important, then they may well be classed as low risk with no need to isolate, and they may continue to work but be alert for symptoms, and obviously if they develop symptoms, they get symptomatic. The other important thing, because there's been an exposure, if it's less than 72 hours since that infectious case was on site, then the practice would close and perform a comprehensive environmental clean, unless they can actually provide really good evidence that they're doing their routine cleaning, they're doing their enhanced twice daily cleaning and disinfection of high-touch surfaces that positive person came into contact with, or if the affected area can actually be closed off to staff and the public while they actually undertake the cleaning and the disinfection. So it can be hard to give a really definitive answer because there's a whole load of risk factors that need to be assessed to determine what the tier level is and then what the subsequent management is of that situation.
Excellent, thank you. And yes, I must admit, I was on a webinar on Tuesday evening where a practice that had been a tier 1 exposure site, and they're an extremely large practice. We're talking about their experience. And the GP was saying, thankfully, they had CCTV. So they were actually able to provide that to the department and show, or prove, is probably the best word, which staff had been close contacts of that individual and which hadn't, including, you know, hadn't been in the area, et cetera, And in the end, it was only 4 staff that actually they needed to isolate as a result of this, this exposure. So I think there's some great strategies that we need to think about and put in place as much as possible. And certainly we have spoken about some of those strategies in previous webinars, which are available on our website if people are wanting to look at those. Andrea also says, and she's right, a lot of people, positive people now are, you know, turning up with no symptoms, which to a certain degree was what Marg was just saying before. And so that obviously is going to create some additional challenges as we move forward. And I did hear someone say, we treat everyone as if they could be positive. And that's, you know, when we do our risk mitigation, that's probably the safest measure. Sophie has just asked that are non-respiratory patients coming into general practice, so screening as if they're negative, considered low risk suspected or not negative, which would mean that in Melbourne, with the COVID peak risk rating, that tier 3 PPE should be worn for all face-to-face consults. So again, this links back to a question that we're getting a lot of, which is, I'm running vaccine clinics. Do I need to be wearing a P2 or an N95 mask during the peak rating? Which is a really quite a tricky one, because if you are considering that if everyone is positive, what does that mean?
Yeah.
And probably the example I could give is, heard of a case last week where a individual had come and had their first dose of vaccine, did the screening, technically not symptomatic, 3 days later tested positive.
Yeah.
What do we do in that situation? So should we be wearing N95s and P2 masks? And what does that mean in general practice, even when we're screening? Are they considered low risk suspected as opposed to, you know, not negative?
Yeah, I think given the current situation, and Marg, please step in, that it's that tier 1 PPE, so surgical mask and eye protection and a face shield is required, because we're assuming they're negative, but we're not really sure. I mean, that's a very good scenario. Someone is asymptomatic, they've gone through the screening process, everything is fine. But if we're wearing the respiratory protection, if the person is then later retrospectively deemed positive, they have had protection, and the risk is going to be low. Marg, have you got anything to add?
Yes, I put myself in the position of saying, yes, look, if you want to consider that the whole of Victoria is, you know, black peak and everything is high risk PPE tier 3, just stop a minute and have a think. We've just got to be really sensible about the way we use our PPE and look at why are we providing care inside continually. We know that outside is much lower risk. And can I say that what I advise, you know, practices who contact me is a patient does not get inside necessarily. I like the doctor or nurse to go outside, talk to the patient first. Can I say that the patient always doesn't tell the truth to the admin staff and the managers? I think we've all heard that, because the patient's anxious that they might not get to see the doctor. But if the doctor, nurses, etc., can go out to see the patient, we're also very big on saying to the patient, do not turn up early, because we don't run a waiting room. I would ban waiting rooms. It makes the admin staff very nervous. We are in the middle of an outbreak here in Melbourne, and I don't know what part of a pandemic people don't get, but I also know that in parts of Melbourne, there are very few cases. Where I am, I think we've had 2 in the last, month, and yet just north of me, half an hour away, of the 766 today, I think 400 are in the north. So I'd be kidding myself if I thought it wasn't going to come to my area, but I can do a better assessment. I think some of the assessments we do at the door, we can improve. For example, we should be adding in headache and runny nose. We know with Delta, especially children and those immunised, the headache and runny nose are quite prominent. We should be doing that. The temperature can be a bit hit and miss. About 40% of people get a temperature. And yes, we can add in the other symptoms. I really make a big play for what's going on in your household. As you mentioned before, is there a tier 1 person? Is there somebody from a tier 1 site? Anybody in your house got symptoms? You're not coming inside. But what I do is I make a provision, either a marquee or a sitting area outside, because a number of consultations, if they can't be done by telehealth, can actually be done outside. Immunisations, we're seeing that happening outside. That means that really my surgical mask and eye protection are really sufficient. They're really, bar somebody coughing over me. And the caution, to answer your question the long way, the caution is, if I think I'll blow this, I think I will just put on the full box and dice, heavy duty gear, for every single patient. Well, I'm standing there like a dummy for 4 hours in all my PPE, changing my gloves for each person. But is that actually a sensible approach? I'm going to get a sore nose. I'm going to be brushing against stuff all the time. I won't be hydrating, and I can guarantee you there'll be a breach.
Excellent. Thanks,
also,
Meg.
will we run out of PPE? Will we run out of P2 masks? Let's keep the P2 masks for when we need them.
Excellent. Thank you for that. So I am very conscious of time. I mean, Andrea, you do make a good point. Not all clinics have outside access when in shopping centres, etc. So I guess just to respond to that point, like I said, we have had a couple of other webinars that have given some ideas around how you can work around this. Certainly pharmacies fall into this a lot too. And some of those things like, asking people to turn up at the time of appointment. So reducing the amount of time that they're actually in your clinic, and then the number of appointments or number of people you've got in that waiting room at once. Certainly, I know in our clinic, we can't have people waiting outside, and it is very tricky from that perspective. But certainly, if you do have or would like some ideas around that, the IPC helpline, we are more than happy to help out and give some guidance on how to implement some of those strategies. I am going to hand back to you quickly.
Could I just add one more thing? I insist that the patient puts on a fresh mask with hand hygiene before they come in. They have dirty masks, they're wet masks, they're not working.
Excellent.
If they've got to come inside, it's a fresh mask.
Excellent. Thanks for that. We have 2 minutes left. I'm going to hand back to you now, Lisa, quickly, just to wrap us up.
Thank you. Thank you for today. Can you please complete your surveys for us so we can provide feedback so we can improve our services? We will email out a copy of today's webinar with a certificate of attendance and a copy of the Q&A. Our next webinar will be on October 28th, and it will be based on the infection prevention control in wound care. Again, if you need any help or advice, just give us a call or contact us via the webpage.